We go.
Alrighty, we're going to go ahead and get started because then we can plow through this and get you back to what you're really supposed to be doing today. So I think I have met all of you. I'm Renee. I'm the director of pharmacy here. And we're going to talk about steps 2 and 3. So a couple weeks ago we talked about step 1, which was just introducing you to the bugs that we expect to see walk in our door here at Memorial Hospital. And now we're going to talk about step 2, which is the bugs and the drugs together. So I'm going to try and link it to what we know about drugs. So we're going to go over antibiotics. We're going to go about how the bugs and drugs work together, talk a little bit about renal dosing, do a case study, and then our last set of slides is about the theory behind antibiotic dosing. So here we go. Okay, so the discovery of antibiotics was in the 1920s, and the large-scale production of penicillin in the 1940s drastically changed the landscape in World War II. It's probably one of the most incredible turnarounds of survival that we have ever seen. So we've had a discovery of approximately one antibiotic drug class, not antibiotic, but drug class, about every 10 years. To put us where we are now at approximately 60 antibiotics that cover about 12 classes, and so they are still less than 100 years old, which is kind of phenomenal when you think back on the time course of human history, right? So these are now commercially available. You're welcome to come in.
I was just going to go around.
No, you can come in and here. No, you're totally fine. We just barely got started.
Right there.
Let me hand you handouts. Where do you want handouts? Do you want them right here?
Yeah, that'd be great. Thank you.
Okay, sure.
It's
So
informal, Sarah, don't worry about it.
It's very informal here. Okay, so it sounds like you're like 60 antibiotics. That's freaking awesome. We can kill off everything. Well, let's find out. So last time we talked a little bit about how one bacteria can produce over 10 million bacteria in 10 hours, and in that same 10 hours, 30 mutations will occur. If that colony is being exposed to an antibiotic, but it is not fully killed, the bacteria with the drug-resistant mutations will be passed on to the next generation. That is a fact. It happens every single time we expose someone to antibiotics, and resistance is born. So the pearl that we need to come away from this is that resistance is primarily caused by inappropriate exposure to antibiotics. Okay, so how do antibiotics work? Well, we have a few basic attack mechanisms, which is why we end up with 12 classes of drugs. A variety of them interfere with cell wall synthesis. So as the bacteria are replicating and dividing, they can't form cell walls to protect themselves. They also inhibit growth, so it really slows down the growth process. They can actually inhibit actual cell division, so then you can't have growth of a colony whatsoever. They can inhibit protein synthesis, which allows the cells to divide, and they can also inhibit the RNA, DNA synthesis transcription. So basically, we've looked for every single way as humans that we know bacteria can survive, and we've tried to attack those different mechanisms of bacteria. And that's why we only have 12 classes, is because that's all we've been able to come up with so far. Okay, this is a topic I just want to briefly mention, because I feel like it's overemphasized in schools and you can't do anything about it. So let's have a little quick discussion about CIDAL versus static. Well, do I need a CIDAL drug? Do I need a static drug? There are people that devote their entire careers to this, and they work for pharmaceutical companies. So the ability of you to wrap your brain around it is really minimal, to be honest with you. Unless you're going to devote hours and hours and hours to this, you're not going to be able to tell the difference. And really what it fundamentally comes down to is you require a CIDAL agent only if your immune system is not functioning. Does that make sense? Mm-hmm. So a static agent works just fine because it just paralyzes your bacteria, think of it that way, in place, and your immune system does its job and goes in and swoops in and takes care of the infection. So that's all you really need to know about CIDAL versus static. And the trickier part that makes this really complex, antibiotics are not always one or the other. And they are one, and if they are one or the other, they're one or the other to varying degrees for varying bacteria. So that's why I say it's a huge, huge topic. When you're at the bedside, just know that, does my patient have a functioning immune system? And if they don't, go to the physician and make sure the physician knows that. That's really all you can do. That's all you can do. Because we have better things in place, easier things in place to read than ponder all day whether we have a CIDAL or a static antibiotic. And we're going to talk about those things. Okay, so let's just talk about some of the things that we know about antibiotics. So we know that in addition to all those strategies that we use to attack the bacteria, that's a nice strategy, but we've learned a few things. We've learned that certain antibiotics have to be have to be exposed to the bug for a certain period of time, and we call those time-dependent kills. And those, the more often you give it, the more likely you are to kill off the bug. Whereas there's other drugs, like the fluoroquinolones, like Levaquin or gentamicin, where it's the concentration of the drug in your system that is going to kill off that bug. And then we have a whole other category of drugs like vancomycin, that it's an area under the curve to the minimum inhibitory concentration that kills off the bug. And those, that's why we need wonky donkey troughs on these. That's why we need to be able to look at that and see troughs. So that's why we do vanc troughs, but we don't do penicillin troughs. It turns out, according to the literature, penicillin troughs don't do us any good, but we do know that if we give those Q6, man, we're golden. We're in good shape. So just know that. It's not important. It's just nice background knowledge. Okay.
Renee?
Yeah.
Why did we get rid of doing peaks? What happened with that?
Okay, so peaks, it turns out, for some drugs are useful and some drugs are not. So gentamicin, it's important to do a peak because we actually can have ototoxicity or a nephrotoxicity, and that's actually directly correlated to what our peak is. Vancomycin, when it first came out, was a very, very dirty drug, and so they did monitor peaks for toxicity. It's been cleaned up substantially, and so we don't have peak problems anymore. Now what we really have problems with is clinicians underdosing it, so we're never actually getting high enough concentrations in the first place. So we did away with peaks.
Okay, thank you.
But these things only come out over time. You know, I think nowadays we do better pharmacokinetic studies, and so we can anticipate that better, but back in the days of Vanco, we weren't really sure what we were dealing with. Okay, and I put this in your packet, which is a really nice thing to refer to. It just basically gives you an idea of what kind of coverage. So over here, we have gram-negative bacteria. And over here we have gram-positive bacteria. Remember how we figured that out last time? It's through our gram stain, remember? And so we can get a gram stain relatively quickly within an hour from the lab. And that lab is helpful because why? Because if we know we only have gram-positive bacteria, we should only be picking a drug from over on this side of the equation, right? If we have no gram-negative bacteria coming out on that culture, we shouldn't be treating that. So that's how that's useful. Okay, so here's our gram-positive drugs that we frequently use here. When life gives you mold, make penicillin, which is kind of funny because that's where it comes from, right? It's a dumb pharmacy joke. So when life gives you mold, make penicillin. Tell that to your kids and they're like, yeah, I don't know what you're talking about. So anything in the penicillin family ends in -cillin, which is awesome because then we know it's in that family. Penicillin only works on gram-positive. End of story. If you have penicillin for a gram-negative, well, you might as well give them water, as far as I can tell. So gram-positives mostly respond to penicillins, but then we have that whole group of people with penicillin allergies, which we'll talk about in a minute. But anyway, this is a lot of penicillins we can use. We have more gram-positive antibiotics, and it's our cephs. So our cillins and our cephs cover gram-positives really, really well. So we've got, our first generations, we've got Ceph, we've got second generation, we've got Mefoxin, we've got Ceftin, we've got Ceftaz, Cefepime, Ceftriaxone. Those are our cephs. They're all really great gram-positives. And if you're interested in the chemistry of it all, you can take a peek at this, but you can kind of see where the cephalosporin structure up here and the penicillin structure down here are pretty similar. So we've got this ring group right here. It's got a sulfa in it. It's got a couple different moieties popping off the end with a carboxyl group over here. We've got this nitrogen thing going on over here, and then we've got another arm over here that looks really similar. So sometimes shapes are helpful in helping you figure out similarities, but also look at the proximities of where our elements add up. And so this is a potential drug allergy interaction, but it is by no means major. We do avoid it to help ourselves out. An awesome study I saw basically said we have cross-reactivity between the two categories 4% of the time. So if somebody truly is allergic to penicillin, only 4% of the time will they be allergic to a cephalosporin. So we're usually pretty safe, so clinicians overthink that a lot. And then we're going to talk about more allergies in a second. I shouldn't get distracted, so don't let me get distracted. Okay, other gram-positive antibiotics. Now this is where we're starting to hit some things that you guys see on the floors a lot. All our carbapenems, our fluoroquinolones, macrolides, the glycolipopeptides, and other miscellaneous random drugs like Bactrim and nitrofurantoin. You've seen all of these drugs here. Don't memorize these, they'll hurt your head. Just know Cillins and Cephs do great on gram-positives, okay? Okay, gram-negative drugs. Cillins don't work. We already talked about that. However, what's really cool is our Cephs have quite a bit of gram-negative coverage, especially in our second and third generation. ANSEF has absolutely no gram-negative coverage. And that's okay, because we use ANSEF where? Where's our big use of ANSEF?
Surgery.
Surgery. And what are we worried most about? We're worried most about contamination from the gram-positive bugs you already have on your skin. That's why we use it. So that explains that. Penicillins are actually okay in gram-negatives if they're combined with a beta-lactamase inhibitor. Sulbactam is a good example of that because the sulbactam piece is the beta-lactamase inhibitor. Tazobactam and Zosyn is why we can cover it. And then the ticarcillin clavulanate or amoxicillin clavulanate and augmentin will cover gram-negatives as well. Okay, we have a bunch of other gram-negatives drugs. Check that out. It's like the exact same list as what covers gram-positives. And we'll talk about why that's important in a second. Okay, let's kind of veer off and talk about kidneys real quick. Our kidneys are our waste removal system, right? And so we know that anything that goes basically in our mouth, in our veins or whatever, at some point, some part of it's probably going to come out of our kidneys. Poor kidney function means less ability to clear most drugs, which means if you're not able to clear it, it's still in there. So we see patients come in all the time with poor kidney function and they're sick. Often the sickness contributes to the poor kidney function. So we may have poor kidney function initially, we start antibiotics and we expect that kidney function to improve, which is why we monitor vancotroughs continuously. We don't just do it once, because if somebody comes in and they're sick and their kidneys aren't clearing it very well, they're going to hold on to that vanco. But pretty soon their body's getting cleared of that infection and then their kidneys start trucking along and start pumping it out, then we might have to boost the vanco dose actually. And so keep that in mind, that we just need to keep an eye on kidney function always, always, always when we have antibiotics on board.
So Renee, so as the kidney function gets better, does the trough go down
Yeah.
sometimes or usually?
Yep.
So that's your indication?
Yeah,
that the
that's your
kidney-
indication that it's
okay.
getting better. And that's exactly why we do it, that's for sure. Although around here, sometimes you're not on vanco long enough for us to pull a second trough, which is fine. We'll talk about why that's important in a little bit. Okay, so here's our pearls from this particular slideshow. Resistance is primarily caused by inappropriate antibiotic exposure. So we put a little too much on, or we put the wrong thing on, or we stop it too soon, a variety of reasons. Immunocompromised patients always require a CIDAL agent. We need to monitor daily for cultures and sensitivities. We're going to talk about that more next. We also need to monitor daily for kidney function, give our doses on time as much as humanly possible, and monitor our vancotroughs. Okay, so here's our quiz. Roughly how many antibiotics are currently available? Does anybody? 60, right. Which antibiotic class should not be used for gram-negative bugs unless it's paired with a beta-lactam? Does anybody remember? Cillins, right. What genetic mechanism allows a bacteria to potentially survive an antibiotic? Resistance, right. What is the number one reason for resistance? We kind of talked about it. Yeah, just inappropriate coverage, right? Inappropriate prescribing there. What do kidneys do for our body? Clean it out, yeah. Could kidney function change during antibiotic treatment? Yes. And why? Because the patient gets better, right? Or we don't hit the right bug and the patient gets worse. What about that? That could happen, right? Patient gets worse, kidney function goes in the crapper. Uh-oh, we used the wrong antibiotic. Okay. What can you do daily to ensure the patient is being treated with the correct antibiotic? We didn't really actually cover this. This is kind of sneaky. It's in the next one.
Daily CMPs.
Right. Daily CMPs and monitoring their clinical function. And then we also should be monitoring for the cultures and sensitivities to come back. What organ should we monitor daily to ensure the patient? This is like kind of redundant questions. I must have been thinking of my 10th grader when I wrote these. Our kidneys, right. And why should antibiotics be given on time? We talked a little bit about it.
You can keep a level of the antibiotic in the bloodstream.
Exactly, great. And then immunocompromised patients require which type of antibacterial agent?
CIDAL.
CIDALs, yep. Okay, there's my answers, there's my references. Okay, let me shift gears. So what we're going to talk about next is actually the antibiotic theory, so that you know where we're going. So we're going to talk about prophylaxis therapy versus actual treatment. We're going to talk about culturing, and then we're going to talk about where empiric antibiotic therapy comes in versus targeted, how to read sensitivities, and then describe the drug access and the importance of allergies. So let's first talk about prophylaxis, because we should totally get this out of the way. So prophylaxis comes in handy for things like surgeries, right? The skip measures guide how often we give a medication. So if you're having a total knee or a total hip, or you're having some kind of an abdominal type of surgery, or there's a variety of them, it will say you give Ancef Q8 for 24 doses, or 24 hours, not 24 doses, 24 hours of doses, so that'd be 3 doses, right? And usually that's one pre-op, you might have one intra-op, and then you might have one post-op, or the last 2 might be post-op. So the patient is being placed in an infection risk situation. They don't have an infection, but we're putting them in a situation where we might accidentally give them one, right? Okay, so why do we not need cultures? Because there's no current infection, so we shouldn't ever be getting cultures on people that are not infected. This is little Miss Healthy. She's been skiing like the dickens, and she totally killed her knee, and the doc's like, oh, you need a knee. Okay, so she goes in, no big deal, right? Okay, 24 hours, we already talked about. There are guidelines on this. We don't just haul off and pick whatever we want for when we want. There are guidelines, and we are graded on whether or not we follow those guidelines. Typical antibiotics used are our Cephs. Can use Cipro or Clinda when we have allergies to the others. Okay, so we got prophylaxis completely off the planet. And let me say one more thing about prophylaxis. It is not, and if you're listening to NPR at all these days, there are big stories on it right now about antibiotic stewardship across the country. And they are even coming down on antibiotic prophylaxis in our meat supply. This is not something we should be doing. Antibiotic prophylaxis should be very limited to very small patient populations that are immunocompromised. HIV is a really good example of that. We'll do very minor, minimal antibiotic prophylaxis, because prophylaxis over a long time can again lead to resistance, and we can end up in all kinds of trouble. So antibiotic prophylaxis is not a thing. I don't know how to say that any other way, but if you see physicians prescribing antibiotic prophylactically, we really need to look at that, and we need to question ourselves if that patient really falls under that umbrella. Okay, now let's go on. Now we're talking about sick people. Sick people, we'd like to have cultures. In as much as humanly possible, we want cultures. Ideally, obtained prior to giving antibiotics, because why?
Because it gets skewed your results.
Yeah, you could come back with nothing, and it'd be like, huh, you're not sick after all, let's take the antibiotics off, and then boom, you blow up into something terrible, right? Okay, blood cultures require 2 separate venipunctures from separate sites. That's best practice, right? So that we can figure that out. Anybody know why that is?
I looked it up one time and I can't remember.
So here's what I was told, and I hope this is true. Otherwise I'm passing on crap. But we could probably go upstairs and ask. I heard that it's actually very difficult to get a culture out of the blood. So they want to make sure that they didn't get something contaminated And so they want to be able to have two different sites, be able to grow it out, and to prove that it truly is in your blood and not just pore collection
That might
techniques.
be right, because it was an answer that I did not expect.
Okay.
I expected something really,
Super gung-ho.
Yeah,
I know,
exactly.
and really it's
Super
just
scientific, it was something like
basic,
that.
yeah. UTI cultures are frequently contaminated. Have you ever wondered why they call it a clean catch? Because we're trying to get it clean. Yeah, exactly, there's no such thing. So, we realize that. Respiratory cultures, this is my pet peeve of all time. I do not want to see sputum cultures, they suck. Why do they suck? They suck because they are super easy to get contaminants in. They are terribly, notoriously wrong. So you'll find that most of our respiratory infections are not diagnosed by sputum culture. They're usually diagnosed by chest x-ray or some other mechanism. So BAL is one way to do it. I think we do that here. Don't we do BALs on rare occasion? Okay. It's nasty, you have to be put out for it. It's basically them shooting a water hose into your lungs and sucking out the results, and it hurts. It's not very fun. Yeah, it is kind of gross. But just know that you should not expect to see respiratory cultures on things like pneumonia. You just shouldn't expect to see it, okay? Wound cultures are also notoriously difficult. They can only get really good ones if they go deep, and deep is in parentheses because I don't know what deep means. I'm not in charge of that area of the hospital, but I do know that if you just swab the top of it, again, you're getting contaminants that are going to be on your skin.
You're just going to get staph because staph is
Staff's
always
everywhere. Yeah. Fecal cultures, also not my area. This is why I grew up to be a pharmacist. Okay, gram stains are usually fast, within minutes to an hour. And remember, we want those gram stains because that should help us guide therapy right off the bat, right? Okay. Susceptibilities, on the other hand, we gotta wait for this stuff to grow. It's not gonna grow and tell us what it is right now, because what I understand from the lab people is, yes, they want to be able to individually look at those organisms, but they look at how they grow as a colony, and the colony growth is what usually differentiates a bug one way versus another. And I am not a lab geek, so I don't know these things very well, but I do know it takes that long. And no amount of fighting or arguing is going to get it any faster. Okay, let's talk about empiric antibiotic therapy. I so wish I had a bazooka, because I thought that would be a very nice visual to show you. Does anybody know what grape shot is?
Yeah, it's like cannon shot.
Yeah, you just stuff a bunch of stuff down your, like it could be, from Pirates of the Caribbean. Remember how they shoot stuff out of the cannon because they put like forks and knives and everything down it in Pirates of the Caribbean, and then you see this fork hit right in front of this guy's eye, and you're like, why did they shoot that out of the cannon? You could just literally pour everything, let the kitchen sink in there, shoot it out, and it just goes everywhere. It's not targeted at all. It just hits every single thing that's in the way. Sorry, I am not going to answer this phone call. That was random. Okay. So we use empiric antibiotic therapy. When the patient first comes in, they're symptomatic, they're febrile, they've got elevated white blood cells, whatever. And we don't have any definite cultures yet. We've taken their culture, but nothing's grown out yet. So we look at where the bug comes from. This is super, super important. Clinicians need to look at the guidelines. There are guidelines for almost everything. If you have a UTI, there are guidelines for that. You and your clinicians need to follow those guidelines. There's actually empiric antibiotic therapy written into the guidelines and says you should start with these drugs. If you have allergies, then start with these drugs. If you have a structural skin infection and you have cellulitis in your lower right limb, you need to start with these guidelines. These are nationally accepted, very well researched guidelines.
And where are these at?
You know what? So this is tricky because each group of physicians or organization has their own. So when we're talking about infection though, a great place to go, a great place to start. Now seriously, I'm going to tell you this and it works most of the time. I would Google it. I would say structural skin infection guidelines, Google. I would say cellulitis guidelines, Google. I would say UTI guidelines, Google. And I would look through your sources to see if anything. I would not choose Medscape. Medscape's probably on top of it as far as repeating it, but it's not going to give you enough information as a clinician to actually make some decision points. Your physicians should be following these. This is absolutely the first pillar and tenet of appropriate antibiotic stewardship. You follow the guidelines. The guidelines are developed by studies that were controlled and done in an environment. Then they were reviewed by experts in that category. A physician in Timbuktu, Iowa, who's practicing in a community hospital, I guarantee you, does not have more knowledge than that set of people. And so we need to make sure that we are all following those guidelines. Now, if you have a question about guidelines, call pharmacy and we can help steer you in the right direction, because we're responsible for those too. So IDSA is the Infectious Disease Society of America, and they cover almost every class of infection that we can expect to see out there. There's other organizations like the WHO, the CDC, there's specific organizations like, if you have bone infections, for example, the orthopods have their own group. And so they're almost always on the same page with a lot of things, but they might throw in their little twist on it or something like that. But they should not be varying and different from each other. And honestly, to be honest with you, this is the physician's responsibility. It's your responsibility to know they're out there and to maybe kind of, you know, if you have a little extra time, go in and say, I'm not sure about this, let me double check this. And if you want pharmacy's help, we'll help you, which would be great. Okay, so yes, empiric antibiotic therapy is a really big gun. And when we have a really big gun, we have a tendency to hit things we didn't intend to hit, right? So we don't go shooting. Also, I'm not very good at these analogies because I don't hunt, so I don't actually know. But I can just imagine that if we're spraying stuff everywhere, we're hitting things and our bacteria are constantly mutating, and the next thing you know, we're creating resistance. So our examples of empiric antibiotics, Vanco, Zosyn, linezolid, any of the penims, any of our fluoroquinolines, Levaquin, ciprofloxacin, these are really big guns. They should be used minimally and for as short a time period as humanly possible. Then we move, I know, don't even get me started. So this little slide is actually going to lead into, Jessica's going to do a presentation next Wednesday on vancomycin alone and appropriateness of it and how we can use it, because that's going to be our best shot. I thought that would cover way too much. Guidelines, 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 guidelines. I cannot overemphasize that enough. That is where we should be going to see how, whenever we use any type of antibiotic ever, actually. We should also use Vanco when we have a suspicion of MRSA. Did this patient have MRSA before? Is the location of the infection typically susceptible to MRSA? UTIs? Like 99% of those are gram negatives. It's probably not. Yes, we know MRSA can live down there, and we have like a colony, and we're colonized, but how many times do we have a UTI that's really MRSA? That person probably is self-cathed or has an indwelling suprapubic catheter or something like that. Then we suspect it. Did they come from a facility that's riddled with MRSA? That could totally help us decide that too. Okay, so let's get off that wagon and move towards targeted antibiotic therapy. So this is more like a sniper rifle. You shoot one bullet and you're aiming for one specific thing. You've stopped with the whole grape shot attack, and now you've narrowed it down, and you're going to fight this one bug. So at this point, we should only be moving towards this point when we have cultures and sensitivities. We shouldn't just haul off and decide this on our own, on an inpatient setting. We're not talking community practice here. We may not have a culture sometimes, like in the case of pneumonia, but we have a narrow range of suspect. Again, we need to look at the guidelines and find out what those are. Targeted antibiotic therapy actually reduces future resistance because, again, we're targeting the one bug that's causing the problem and we're not hitting everything else. We always look for the most effective drug with the least collateral damage. And if you think of empiric therapy, there can be a lot of collateral damage, right? Okay, so time out. If empiric therapy kills more bugs, why don't we use empiric therapy all the time? I'll give you an answer. It's resistance. We're blasting away indiscriminately, and we are not necessarily hitting all of those bugs as hard as possible. Also, has anybody ever given any thought to what happens if we clear our entire system of bacteria?
C. diff.
Yeah, and it turns out that's on the rise, right? So that's no fun for anyone. Okay, let's talk about how cultures and sensitivities can come back. This is the basic information. Our lab doesn't necessarily report it the same way. So our gram stain on the top. In most cases, hospitals report results as pending or final. If you know it's final, you mean it's done for the day, and we can probably act on that. Even in some hospitals, we act on the pending. Second line means this is the type and shape of the bacteria. So we have gram-positive foci. So what that says is there's no gram-negatives there. So I need to start looking at my gram-positive drugs. We have many white blood cells. Okay, that indicates an infection. We probably already knew that. And the fourth line is just the confirmation of who was called when. Okay, so here's where we get to the meat of it. Our culture should tell us where. Do I have a little pointer? Ooh, pointer. Ah! Hang on, pointer. There we go. It should tell us where the culture came from. So this was a blood culture. And then it tells us what the bug is. So this is Staph epidermidis. And then here's where it gets tricky and people totally get tied up in their underwear all the time. So just remember, this is tricky, and if you need multiple reminders, it's A-okay because it's a discussion we should have many, many times over. So because it was a gram-positive, the lab didn't go and test it against a whole bunch of gram-negative drugs. What they have in the lab is they have literally, it's a little tray. This is my gram-positive tray, impregnated with a bunch of gram-positive drugs. This is my gram-negative tray, impregnated with a lot of gram-negative drugs. If it's just gram-positive, they're just gonna stick that in there and see what happens. They're not gonna test it against everything. Another thing to keep in mind, the panels on those little trays don't necessarily contain all the drugs within that class. So the testing companies have figured out that, let's see, oh yeah, this is a good example right here. So the testing companies have figured out that if they tested it against Levaquin, they probably don't need to mention Cipro up here too, right? Mm-hmm. So then you can interpret that to mean that's across the category, across the drug class, okay? So that's how this group of drugs got to be tested. Now, the MIC part is where it gets tricky because people want to compare this. They want to say, you know what? What's my lowest number? Well, it's Vanco is my lowest number and it says susceptible. That must be the best option. That's not how this works. Mm-hmm. These numbers are specific to this drug. So for example, let's pick, chloramphenicol is a crappy idea. Let's pick
that anymore?
Yeah, it's still out there, which is probably good for us for later in case something crappy happens.
Yeah, just trash everybody's liver.
I know, right? That's probably why nobody uses it. So, so what we want to do is we want to look along, first of all, we want the susceptible. So right off the bat, we can cross off anything that's resistant. And what we see here is ceftriaxone. Can I see that part? Yes, I can. Okay. So ceftriaxone has its own minimum inhibitory concentration. And when they've run drug tests on ceftriaxone, they have said that if it's over, if it's over 4, I think if it's over 4, then it is resistant, and so we don't want to use it. But that is specific to ceftriaxone. So when it says resistant, we definitely want to cross it off, and then what we want to do is we want to look at our susceptibles. So we have, okay, chloramphenicol, we're not looking at that one, I remembered. So let's say we have gentamicin on this one, and we have any one of the tetracyclines. We also have Bactrim, and we also have vancomycin on here. And you know what, this is a blood culture, so maybe this person's, kind of got a little bit of sepsis thing going on. And we say to ourselves, okay, so we want to look at our gent option, our tetracycline option, our Bactrim option, and our vancomycin option. We don't really necessarily suspect MRSA in this patient, so, if we can avoid using that one, that might be kind of good. But then we look at this and we say, okay, so I've got a choice between my Bactrim, my tetracycline, and my gentamicin. They're all susceptible, so we can count those as equally good. I'm not going to go into this too much. There's actually a little bit more to it, but that's what you should be looking at from a floor standpoint. And then you say to yourself, well, is my patient sulfa allergic? He is. Oh crap. Well, we got to cross that one off too. Okay, so I've got a tetracycline I can give IV or a gentamicin IV. He's young and healthy, and his kidneys work pretty good. Maybe I'll lean towards gent. Okay, so I decide, well, in tetracycline maybe making our stomach unnecessarily nauseous for whatever reason, so maybe that's why I decide gent. So I decided to go with Gent. So this MIC number cannot be compared. Just remember that. These cannot be compared one to another. And if you get confused about that, call the pharmacist downstairs and say, explain to me again why we might want to use this drug over another drug. Sometimes we're just stuck with our back against the wall and we're susceptible to one thing, or even worse, it's this little bugger right here. It says intermediate. That means it's between susceptible and resistant. That's no help at all, right? But sometimes our back is against the wall and that's what we're going to use. Now, a final word about this. What this means, all this stuff this lab did happened in a Petri dish. Petri dish is not our body. So it's in vitro versus in vivo. So what that means is in the Petri dish, we had bug coming head to head with drug. But guess what? Drugs are not all created equal. Some of them can't get to your bladder. Some of them can't get to your lungs. So even though that infection is rampant and running through your body, and I've quote unquote got a susceptibility of 4 for gentamicin, and gentamicin can't get to where it needs to go to, then that's a moot point. Because I can give them all the gent in the world, but it's not getting to where it needs to go to. So these are external, ideal world susceptibilities. So keep that in mind. So I'm not asking you to make a decision on this, just keep it floating in the back of your head, and that's truly when you need to involve a pharmacist for sure. Okay, time out. Ha! We talked about this already. What if my patient isn't on any of the drugs listed? The drugs represent certain families. So you can check to see if your drug your patient is on is in that family. Honestly, you can Google that or LexiComp it and you can click on that. Or you can call your pharmacist. We love helping with that too. What if my patient is on a drug that is labeled resistant or intermediate? I would call the physician immediately and make sure they are aware of that. Because that's sometimes something that doesn't get passed on, or they see cultures after you do. Okay, we talked about this a little bit, the Petri dish problem. And the reason this is a problem is because the physical size of the drug molecule itself actually matters. Vancomycin is a freaking huge molecule. Vancomycin has very limited access to your brain. So if we are treating a brain infection, interestingly enough, we can use vancomycin. We just have to add on another drug that gives it access called rifampin. And so that's really awesome, but you have to know that. Not right now, you don't have to know that, but later you do. Okay. Lipophilicity, so is it a fat-loving or a water-loving drug? That matters too. The metabolism of the drug molecule matters. Our liver is where this comes in. It's our main protection against foreign objects, and the body sees drug molecules every single time as foreign objects. And so we don't get enough clearance through our liver of a certain drug, then we're not going to get high enough serum concentrations. Don't get hung up on this. This is another area where people spend their entire lives figuring this stuff out. Just be aware that if you don't see your patient getting better, we maybe have a mismatch between the drug and the infection location, as well as the drug and the bug. Okay? So it's not all about drugs and bugs, it's also about drug and if it can get to the site of infection. Okay, allergies. We need to talk about these. Allergic reactions can be very severe and even life-threatening, and antibiotics are the class that we see that have the highest reported allergies. If penicillin is listed as an allergy, we need to clarify what that reaction is. Anaphylaxis is a lot different than, oh, I got a little bit itchy. And we all know that, but it's just a really good reminder, right? If sulfa, and the reason we want to clarify this is because penicillins should be our go-to. They're very narrow spectrum drugs that work really well when we use them appropriately. We don't just want to bypass that entire category of drugs when that could have helped that patient. Sulfa is listed as an allergy. That's always Bactrim or Septra, and then Dapsone as well. If vancomycin is listed as an allergy, and I'm going to go back to talking about it, back in the day vancomycin was a very dirty drug, and that had to do with manufacturing practices. Our chemistry has gotten a lot better. We're able to put out a much purer practice. Very few people are truly allergic. Very few people are truly allergic to vancomycin. In all likelihood, they have red man syndrome, which can be alleviated by slowing the rate. And so we want to make sure that's the case, and we want to test that in the moment rather than saying, well, they're allergic, got to get rid of it. Because Vanco is our cheapest MRSA drug. And if we have to slap them on Dapto, right off the bat, that's, I think, about a $700 a day patient charge. So if we can do Vanco, rock on. Let's try and solve that problem first. Okay, pearls of wisdom. Targeted antibiotic therapy reduces future resistance. We need to check for cultures. This is going to drive you crazy. 3 times a day to ensure rapid transition to the appropriate antibiotic agent. Empiric antibiotics should not be continued past 48 hours of initiation. That is an IDSA guideline. And so we really need to stay on top of that, because what that is doing is that's just creating further resistance if we do. Call a physician when the cultures and sensitivities come back, because maybe they haven't seen them yet. There's nothing that pops up on QuadraMed on my side that I know of that says, hey, your cultures and sensitivities are finished. So we need to let them know. Verify that the drug matches the sensitivities. Pop that up and say, hey, oh yeah, that looks about right. Or hey, that doesn't look right at all. Let's call pharmacy and see if they can help us figure this out. And then always ask yourself, is your patient getting better? If your patient's getting better, we probably have a pretty good match. If your patient isn't getting better, we need to shift gears. Okay, real quick case study. DC's 35-year-old male who presents to the ED with a fever. He's diaphoretic, tachycardic, and tachypnic. He has a leg wound that is visibly purulent and poorly dressed. He's allergic to sulfa. So those are his labs. Should we start antibiotics?
Yes.
Yes. Based on what findings?
Fever.
All that malarkey I just listed. Okay, what type, empiric or targeted, of antibiotic therapy should we start and why?
Penicillin.
Well, maybe. So we would want to start empiric, but we don't know the bug yet. So we want to make sure that what we pick matches IDSA structural skin infection guidelines. So we might, if we were the doctor, we might look that up. I would hope we would. And we would say, alrighty, and I know where to go with that. So what type of bug would we expect to see? A gram-negative or a gram-positive when we're talking about a leg wound that's open and oozy and gross?
Gram-positive staph.
Gram-positive, right. Although we can't necessarily rule out gram-negative, right? So one of the empiric antibiotics we might expect to see would be vancomycin for gram-positive and potential MRSA coverage. But we may also want to add anazocin, exactly, because zocin's got some gram-negative stuff that really does good things, right? And then how long would we expect to see them on it? Say they decide to admit him. 48 hours or less, right? Exactly. Okay, so what type of culture is this? Can you guys see that far? So that's a blood culture. I think we probably thought he was.
E. coli.
Yeah, nasty, huh?
Ah.
This is actually, and that surprised us because we weren't really expecting it, right?
I don't know, is he rancher?
I don't know, maybe so. That could explain that, right? Okay, and so that is what's special about this. So we maybe were thinking sepsis because we had a blood culture going on there, which, hang on a second, make sure I go forward. Okay, and that requires 2 venipunctures. Which bug is in the wound? We talked about E. coli. Which drugs show susceptibility? I cheated and highlighted all of them for you right there, right? Okay, so which of those that he's susceptible to should he not take based on something maybe you saw in his history?
The last one.
Right, exactly. Yep, and then anything too that's resistant or intermediate, if we can avoid it. So the ampicillin, the unicin, levaquin, and the Cipro. Okay. Oh no, my patient's on Cipro, what should I do? Call the doctor, exactly. And let him know, hey, we totally screwed this up. This isn't going to work for this guy.
Nobody's gonna start on the Cipro.
Well, one would hope. Never say never. We can all screw up.
Just saying. Just saying.
So anyway, I wanted you to have the slides so that you could go through those and remind yourself. That was a very quick slam dunk of a lot of pieces of antibiotic stewardship. But the biggest message is involve your coworkers, involve your physician, involve pharmacy, because the more heads are looking at it, the better. And we all know our physicians are pretty maxed out time-wise. And so if we can be helping them look for cultures and sensitivities, if we can just review it and say, I question this, even if you're not questioning whether it's wrong and you're just questioning why somebody would do something, that's a good education moment, right? I like those moments for myself. I wonder why so-and-so is doing this, and I get on the phone and I say, teach me how you do this. Then I think that's something we can all learn from. We should probably have this whole segment separately as an outpatient, because there's actual differences in how we practice on an outpatient side, because we often don't get cultures before we start treating something. And so we should probably have a discussion about that a little bit later. But my message on that is look at the guidelines. There are always guidelines for outpatient. Always, always, always. Questions?
Yeah.
Yes, Charlene?
Go ahead.
If we're giving these empiric antibiotics beforehand, how is that not creating resistance?
So-
If there's guidelines of how much exposure they need to have and they're not meeting it,
Right.
because you're changing it.
So in reality, we are.
Okay.
In reality, we are. And that's kind of the sucky thing, and I think that's where the experts in their fields are trying to weigh the risks and benefits of what they recommend as empiric therapy. Because not all guidelines will recommend you come out of the woods blazing all guns, you know. But some infections that are life-threatening, like endocarditis, we're going to throw the kitchen sink at it.
Oh, yeah.
We're going to just blast it. Other infections, we're like, you know what? Yeah, you look like you might have a touch of this, but you're not like super, super sick. You don't even really meet the guidelines for sepsis, but you are ill. We're going to tone it down, and we're going to start with this. But you're exactly right. You are exactly right. And so I think that's where the clinic piece actually feeds into it. So how many of us, and I said this last time, how many of us go to the doctor and expect us who are healthcare providers, go to the doctor when we're sick and expect them to give us what? A pill. Yeah, no matter what it is, give me a pill. We like to flatter ourselves and think patients come to hear our medical advice. I don't know that I've actually ever wanted that, even in myself. When my kids are sick, I don't want your medical advice, fix this, right? So it's our responsibility to figure out how we're going to educate our patient population, because this actually starts in the clinics. How many times have we seen antibiotics prescribed for the common cold? Just in case. Well, yeah, they're going to get better in 4 days. Well, that's because that was the natural course of a common cold, right? They've been sick for 3.
For RSV
All the time.
I mean, constantly.
All the time. And we do it because they expect it and we feel pressured. But what we need to do is turn that around, and we need to take the time to explain to them, I'm sorry, I am not going to do anything for you. I am going to explain, and honestly, I think it'd be awesome if you called pharmacy and we could be the bearers of bad news. That'd be great. Sorry. Right? Right. Because then you can blame it on them and say, well, they wouldn't let me. You can totally see the predicament I'm in. The pharmacy won't let me. But I do think that's a discussion we need to ask ourselves and think about how we approach it when we go to the doctor. You know, I know better, and yet I still take my kids when they're not feeling well and it's day 4 of a fever, and I know darn well the signs and symptoms of, you know, a viral infection, and I still show up and I'm like, okay, I really do want something for this. I don't think it's viral, and they look me straight in the face and they go, you know it's viral. But they feel comfortable telling me that because they know what I do. But they don't feel comfortable telling their neighbor who comes to see them, and they risk losing that patient. It's very real. It's very real in the family practice clinic. They risk losing a patient if they don't treat that patient with something tangible. So these are discussions we need to have, and we need to support each other in those. Okay, I'm done yapping. What was your question, Charlie?
Well, this is kind of